morning, everyone. My name is Sineva Hackman, and I am a program coordinator for the Delta Regional Community Health Systems Development Program with the National Rural Health Resource Center. I'd like to welcome you all to today's Kickoff webinar. We're really glad you could take the time to be here with us today. Before we get started, I'm just going to go over a few housekeeping details. When you call in, your phone line will be muted. To unmute or to remute your line, press *2. Once you call in, please keep your computer speakers on mute to avoid any echo or feedback. You can communicate via the chat box on the left-hand side of the screen at any time. We will go over questions at the end of the presentation, or if you have a question during it, you can use the chat box. The file share box, which is located directly below the chat box, will have a copy of today's webinar materials. When you click on the name of the file in the file share box, you can click on Download, which will download that file directly to your computer. Today's webinar will be recorded, and a link of the recording will be provided to you once it is uploaded to our website. Now I'd like to turn it over to Kate Stenyum at the National Rural Health Resource Center to get us started.
Great. Thank you so much, Sineva, and welcome everyone. Good morning. This is Kate Stenyum with the National Rural Health Resource Center, and I just want to take a minute to welcome all of you to the call today. I believe I probably talked to every single one of you on the phone and had the pleasure of meeting most of you out on the meet and greets this last fall. So great to see everybody joining us for the first Delta Region Community Health Systems Development Cohort 2019 Hospital Clinic Learning Collaborative. I just want to go over a couple things before we get going with our topic and with our speaker today. This is what we'll be doing. We're going to do some welcome and introductions, and we'll get to that in just a second. And then we will be doing, Shannon Calhoun is joining us today as a subject matter expert, and she's going to be doing a presentation on the big picture and why results matter. And since we decided, we know this is the kickoff webinar, but since we have all had phone calls and all of the meet and greets have been completed, we know that everybody's feeling really confident and comfortable with what is all entailed within this 3-year program. And so we decided that this would be a great topic to kick off on our first webinar together. And really looking at, Shannon's going to talk today about, in order to survive the changing financial landscape, how hospitals need to demonstrate your value. And so she'll be discussing how you can document and demonstrate your value in order to tell your specific value story. So we're really looking forward to that. And then we'll also have time for questions. But I do want to bring to everybody's attention, the lines are muted, as Sineva had noted. If you have a question at any time, you can press *2, and that will unmute your line to ask a question. Or if you look at if you're looking at the Adobe screen over on that left-hand side, you can see right in the middle, it says chat. You can always type a question in there as well into that chat box. So just a reminder, we are the National Rural Health Resource Center, and we are a nonprofit organization dedicated to sustaining and improving rural health care. We are the technical assistance provider for the DRCHSD program. And the funding for this program comes from the Federal Office of Rural Health Policy in partnership with the Delta Regional Authority. So before we get started, here's a list of the Cohort 2019 participating communities. And what we're going to do right now is if everybody could use that little chat box. Again, if you look at the left-hand side of your screen, right in the middle it says chat. And in that chat box, if you could enter your name and your facility, then we'll get a really good idea of everybody who is on. I see people are typing away, so please enter your name or the names of the people with you and the facility that you're with. That's great. Thank you so much. I also wanted to bring to your attention, we have a couple great new resources. Both of these resources were developed and then released just here in October. And they were, the subject matter expert that pulled these together for this program was BKD. Many of many of you know BKD because I know that a lot of your facilities use them as your auditor, and they are also the consultants that will be on site with you for the revenue cycle management and physician practice management consultations. But they worked this last fall to update a best practice guide in revenue cycle management. And so that is available and located on our website, and the link right in this presentation will take you right there. And then they also developed a 340B drug pricing program guide. So I wanted to bring that to everybody's attention too. It's very well written and very easy to understand and easy to use. So I would recommend checking out both of those. So with that, we're going to go ahead and get started. I'm going to introduce Shannon now to take over, and she is going to be talking to you about the big picture and results matter. So Shannon, please take it away.
Good morning, everyone, and thank you, Kate. I'm excited to be here and join all of you this morning for your kickoff webinar. Briefly, I have been in healthcare about 25 years. I managed a network that was owned by rural hospitals for almost over 20 years. And really the focus I had there was group payer contracting and interchanging with providers and payers. I also have about 5 years of experience in engaging in alternative payment models and also practice transformation. So I look forward to all of you engaging and having questions with this. Thanks again to the National Rural Health Resource Center and this project for allowing me to offer you hopefully some information. Today I want to give you a little context, and I would say that almost everything I have to say in this presentation is in regard to what your data says to purchasers of health care. I think that that is probably a highest priority of how you present yourself to purchasers of health care. So we're going to talk a bit about that. And for a good example, I spent some time just Googling rural health value or value of rural health care. And what I found was two different buckets of information when you talk about value, not quality, but value. And one bucket was really about all the different types of quality measurements and processes that are in place for either in hospital or just in rural healthcare in general. And the other bucket was about economic impact, much like this slide, which talks about the vulnerability of rural healthcare. And this is all critically important. But what I found hugely missing was talking about the real reason why rural healthcare providers exist and what they do to deliver. The story is not out there. There's not a story that leads the importance past economic impact. And so I think that really is a telling position for this conversation. So today's agenda, what my goal is to number one, give you some background. How did we get here? Why is this a conversation? And then talking about the drivers of change and the direction of change. I'll also then break that down into specific rural barriers, because all that change of driving transformation really is applicable to everyone in the United States today. But then there's some unique things in regard to rural providers, and that includes the unintended consequences that happen, really how to demonstrate that your hospital matters, and obviously the impact of healthcare changes not only in general but worldwide, that this is not unique, specific to rural, but sometimes we feel like the disparity is specific to rural. So with that, we'll move on to healthcare transformation, and I feel like this is a bit of a worn-out word. So I want to make sure that each of you really understand that it's here to stay. One of the things I encountered in the last 5 years was there seemed to be a little bit of a holdout that we really don't know what the next platform to stand on is. And so I want to make that case for you of I believe there is a platform, perhaps maybe a platform of change, but it helps to know where that's coming from. So first and foremost, I was very privileged to participate in Initiative 1811, and this study that was held by the Kaiser Family Foundation and the Society of Actuaries here in the United States. The question they posed was, what can we do about the costs of health care? And that really leads to the name of the project, 1811, that basically says that in the U.S., our healthcare represents 18% of GDP, where all the other developing nations in the world, represent around 11%. We're almost double in what our cost is against the national spend. So this study actually stands on top of the 2017 Commonwealth Study. And this one I find very interesting. We talked a lot about cost in healthcare transformation. But what's interesting in this particular study is that it addressed 5 areas: care process, access, administrative efficiency, equity, and healthcare outcomes. So you can see it's a lot more broad than just what the spend is. And what's really concerning is that the U.S. is overall last across that 13 developing nations in the world. We're broken out by topic. We are last or next to last in all but one, and that is care process. So you can tell that this view of why is there change is really not just unique to the U.S. There's a change afoot in the world, and certainly the U.S. has a big problem. So drilling down just a little bit deeper, in 2016, ARC, or the Agency of Healthcare Research and Quality, actually announced that more than half of the cost of healthcare is attributed to 5% of the population. That's called the 550 population. And we used to say, even in business, not just in healthcare, but 20% takes up 80% of the 20% of the population takes up 80% of the cost. And so this is an escalation that is what is now referred to as the chronic disease burden. So it's also about sickness in the country, as well as in this healthcare delivery form. And it sort of shows evidence that this escalation of the chronic disease burden is driving some of the complications of what's happening in the healthcare system. Of course, Medicare, the largest insurance company in the United States at least, really took the lead on this. And it's not stated here, but what we know is that one of the interesting things that happened starting around 2011 is that there was the entrance of the baby boomers into the Medicare populations. This was one of the largest cohorts in mass that entered into the Medicare populations. And so not only are they concerned about the total cost or the cost curve, because that is escalating, but then with the exponential amount of people moving into Medicare, it's sort of sounding that alarm bell that there is a place in which the system could break because of this escalation exponentially of the disease state and the cost. So this slide actually comes to us from the Learning and Action Networks early in the transformation programs, and there's 2 important things to note. One is in that dark blue arrow on the left, and it notes the pillars, the 4 pillars of which almost all of at least Medicare's transformation is standing on, and that is provider accountability and innovation. And I think that's interesting to note. Think about the innovation as we talk forward. The impact of payments of cost and quality performance. So payments that they are paying you need to be impacting the outcome of cost and quality measures. And then delivery system integration and coordination and patient-centered care. So those 4 pieces you're going to see in almost every type of new payment methodology introduced by Medicare. The second is that these 2 XY graphs with bubbles on them, one shows the current state. Of course, this was around 2014. But what's interesting to note is the largest bubble is fee-for-service. So fee-for-service is traditional Medicare payments, and then it moves across as observed about 6 years ago. The intention is for Medicare to move everyone that is possible out of fee-for-service. So what you can see on the right-hand XY graph is that they're moving them into other categories of payment methodology. And so what's interesting to note that I felt that was a good omen is that they're not just moving the orange bubble all to the right and we all have to move to only one payment methodology. Their intention is to make sure that there's success and the ability to participate in some of those payment methodologies. So if it's too small to read, I'll just cover. Category 1 is fee-for-service, no link to quality or value. Category 2 is fee-for-service, linked to quality and value. That's a lot like the Merit Incentive Payment System, or MIPS. You still get paid the same way you get paid, but you also have an opportunity to participate in the reporting for cost and quality. And then category 3 is alternative payment models built on fee-for-service architecture. The best example of that is the MSSP, or Medicare Shared Savings Program, ACOs. This originally was still where you receive your current fee-for-service payments, but you share in the up or down of the spend of the population. And that's probably the most popular, especially for rural communities. And then finally is category 4, population health, or global payment type arrangements. So what I want to say is that was specifically focused on the entire Medicare provider group, which is everyone who sees Medicare. In May of this year, CMS's Seema Verma came to the National Rural Health Association National Conference in Atlanta, and specifically to say that they are, quote unquote, rethinking rural. I think that's an initiative that they've named it. But they are making sure that there is opportunities for rural offerings. Those include special support for small, underserved, and rural practices, helping them to participate in the program, giving them training and support. They've also promoted new codes. The newest at the time was the telehealth payment policies, but that also included the care coordination that started in 2015, 2016. So they're paying for new types of services we haven't seen in CPT codes. They're also trying to accelerate the use of telehealth, and so not only do they have that new payment, but they're working to expand broadband. And that's been around for a while, but I think they're becoming very specific and hopefully having greater outcomes in that expansion. They also did this year the change in the Medicare wage index. That's been around since forever, and a huge disparity to rural providers being able to hire competitively. Then finally, they're announcing new value-based payment arrangements that are under the primary care initiative. So they're making an effort to focus and help rural providers, but what you might note is there's a few things that are not off the table, and that's what's not included in her offer. She is not including the idea that they will remove the value imperative, and that is the measurement of accountability for cost and quality. So this is sort of a stake in the ground to say, whatever methodology, whatever position you have, future payments of Medicare going forward will be connected to cost and quality, and the results will impact your revenue. So it's sort of understated, but it is absolutely there. So I think that's part of the reason why we're having this topic today. Payer for rural providers for a long time is Medicare, and so I try to leave words, not notes, in the bottom of my slide presentation so that you have this as information to go back without having to try to remember it all. The point is, Medicare has an intention that they will bend the cost curve, and they will do that while purchasing high-quality services. In other words, when they're buying health care on behalf of their beneficiaries, they intend to know that there is high quality. And in doing this, they actually are putting out pieces and parts that seek to change the system, and that's not exclusive to payments, but also to delivery. So we're seeing changes of the results of the payment models to actually sort of push around some of the delivery that we've had before. And then to follow that, what's really important and not widely spoken is that engaging in transformation is moving to some type of risk. Whether it's downside risk or not, is still holds true, that ultimately everyone has to take some kind of risk that Medicare recognizes. I would say it's a risk to engage in transformation for rural providers, no question, but they want participation in their type of risk. You also need to know that engaging in transformation in this way, providers that take risk and greater risk actually have an advantage over others who are not. For instance, for everyone participating in the merit-based incentive payment program, the weight of being able to be measured at the top of the results of that program are that the weights are given in favor of those already taking risk. So you may think, okay, I'm just going to stay in the MIPS program. I don't have to get into any ACOs. And meanwhile, I'm participating with the opportunity to get in the pool. You can work really hard, but you're going to have to work double on quality just because there are a couple of weights that advantage those that are already being measured somewhere else. So it's sort of stacked against you in not participating, and I think that is an intention. They are pressing hard for people to move. And finally, in particular in regard to the Medicare fee-for-service fee schedule, there is no increase. It is frozen at 2015. There is no inflation moving forward, and the increases in the future will start in 2026, and they are directly related and correlated to the participation in the alternative payment programs. So, yes, there are rural participation, but moving forward, if we were to collectively say we need help, you have to be demonstrating your quality and your value. Otherwise, we're just not recognized. And I'll explain that. I want to cover just a few more things about what's happening in the landscape. And there's a changing healthcare market. The first, of course, is this payment methodology that you see. And in 2010, and well before that, the government payer segment is that dark turquoise, and it was more than 80% that was your Medicare, Medicaid, self-pay, no-pay, indigent program. As late as 2015, or as recent as 2015, it came down to less than 50% of what the platform that rural providers actually really speak to, which is the Medicare fee-for-service. What you need to know going forward and looking specifically at this slide deck and these three bars is that Medicare Advantage falls out of that blue bar. Medicaid MCOs fall out of that, and they are all subject to these other types of payment methodologies that we're seeing today. And so rural providers who have managed their payer contracting, managed how their delivery system goes, was focused wholly on Medicare fee-for-service, really is not a solid place to be at this point. The other thing is the government and commercial payers. This actually was a study, again, by the Learning and Action Networks, which were part of the support teams for the Transforming Clinical Practices that started in 2015. And you can see, and since it's small print, I'll share this with you, but the bars in green are 2015 studies, the bars in blue are 2016 studies, and the bars in 2017 are orange studies. So you can understand the breadth and depth of this. The 2017 study was 61 plans, 3 states, plus Medicare fee-for-service, representing 226 million lives, or 77% of the U.S. covered population. So a good 3/4 of the country was in this study. And what you can see over time is that those categories that we saw in the bubble chart with straight fee-for-service over to full risk on the far right-hand side, you can see the decrease over time of participation in Category 1, and the increase varied across Categories 2, 3, and 4. So the payer market is moving in that direction, not just the payment methodology types, but the payer market. And then just to add one more unique thing that's happening in the marketplace is the demographic changes. While we see this large en masse entrance of the baby boomers, which are part of the aging with young and other folks who are very focused on convenient access to primary care through technology. And that's almost the opposite end of the spectrum. Again, something that is not what was specifically addressed in rural marketplaces, broadband connectivity being one of those problems. So those changing fragmented components of the marketplace really create additional costs and duplication of effort, not only for you, especially the rural providers, but this sense of change and unknown is happening, of course, for our patients, but also for the payers in healthcare. So all this state of affair really sits to say that the current state is not sustainable and that there is no option but to change your payment and delivery system. Now, there's good hope in this, and so hopefully I'm not painting too hard of a picture, but I really want you to have the good understanding of what's driving this and where we have opportunities. The one other thing that I feel that this has been around a really long time in my payer contracting days. I felt that the small number that rural providers represent, even as a collective, but specifically in their own market, creates that they're exceptions to the norms, and this in and of itself is a problem. So I call this actually the tyranny of small numbers. And even today, our delivery and payment methodologies are defined and are limited by small numbers of patients that we serve. That's where RHC comes from, rural health clinics, cause, all of those things really come from the idea that we're small. And this isn't unique to rural health. Those of us that live in rural communities, I grew up in a rural community, I live in a small community now. Schools, cities, counties, telephones, electricity, all struggle to create an economy of scale and scope in order to act as an enterprise, in order to have some relevance in the marketplace based on volume. So we have lived for a long time as rural people and rural providers as having unintended consequences, and that really the unintended consequence in this instance, in the context of today, is in statistical terms, we are considered outliers. So I want to explain that just a little bit, and I won't belabor it too long, but it's fascinating to me. So everything that's happening today that I just described, competition, perceived relevance, demand for quality, and demand for value, are all study-driven and applied based on statistics and data. And so what you need to know is that though we have never marketed before, number one, because we are the only game in town, and so that's a single provider, then there's one historically data sets were driven based on tyranny of small numbers. But that status quo is not translating to today's marketplace because a huge chunk of Medicare is moving over to the commercial side, and the commercial side is applying their analysis without the tyranny of small numbers in their projections. And I'll explain how they're doing that. They may not say that, but I'll explain how they're doing that. So just to get a little geeky, in statistics, an outlier is a data point that differs significantly from other observations, and it may be due to variability or it may be due to some type of error. An outlier of either reason can cause statistical analysis problems. So even if we just look at us in numbers and not any other thing, we are outliers. We lie outside, either in larger or smaller, obviously or smaller, but we lie outside of the data sets that are being used to study all of those things in competition, demand for value, demand for quality. And so this is an important opportunity, I believe, and that outliers range from being unimportant to being really important. Unimportant outliers are if they capture inaccurate information or if they carry little weight. If they carry a lot of weight or they present something more than the norm, then they become very important. And I think that's actually where we have a huge opportunity. The other thing that I found, so I did some research talking with friends that are in the payer community, and I talked to a friend just this week about, she works in the bundle payment arena, so really sort of global payments based on disease state. And I asked her, how do they manage statistical outliers? And she said, oh, it's called Windsorizing. Windsorizing is the transformation of statistics, literally transforming what the statistics say by limiting extreme values in the statistical data to reduce the effect of possibly spurious outliers. Now, what that says, and literally what she said in this whole calculation for bundle payments, is that they scrape off the top 5 and the bottom 5% of the outliers without consideration. It's just a statistical thing that happens that people choose to use Windsorizing. I found that really fascinating and hugely disconcerting. And I guess the reason why is that the people who are buying healthcare are using this type of data to determine their risks in delivering care in our marketplaces, and the result is that they are identifying and ultimately excluding outliers. Let me explain. I also spoke to a friend who's a CEO of a Medicare Advantage plan in the Northwest, negotiating on behalf of rurals in a group to be able to say, how can we show our value to you? Because, like, for instance, a lot of times they want to carve out labs and use the reference labs instead of the CLIA labs that are in hospitals because we charge more on a click fee. The reality is, if we take that away and reduce the opportunity to have the labs that we have, then ultimately we can't do the other services that we have outside of just being a lab. And that was a fight for 20 years to actually get acknowledgement of that one piece, because they are looking at clicks and not looking at comprehensive whole outcome. So I had this idea, let's negotiate a network just for rural providers based on our metrics. And this person, who happens to be a really nice person and not what I would call on the dark side, said, but why should I care? Literally, why would I care about protecting a cohort of types of providers? And I said, because healthcare is local. And her answer was, if they're not demonstrating quality, it doesn't matter if they're local or not. We're going to figure out how to get them to a place that we see as of quality. And that was this year I had that conversation. And I think that's a real happening, is that if we are not showing what our data shows, that we are of high quality in their language, then we are being bypassed. And that raises the hair on my head. One other example, and I found this one really interesting, and this was happening even before we really started talking about transformation. Blue Cross Blue Shield in Texas decided that they would take publicly available data, and that meant like Six Sigma and Leapfrog and other things that people can participate on and then post in their marketing side of, this is how we're of high quality. So they measured 427 hospitals in Texas with publicly available data, didn't even talk to the providers at all. And by the way, these were all providers who were contracted in Blue Cross Blue Shield networks. But what they did was then rank every provider based on exceeds, meets, does not meet, not enough data, or declines into groups: the Blue Ribbon Network, the Light Blue Ribbon Network, the Clear Blue Ribbon Network. And most of the rural providers fell out of these types of networks simply because they don't use the type of they don't engage in the type of publicly reporting that a lot of large systems do for competition. And so what Blue Cross did with this network was then offer that to every Medicare beneficiary. Didn't even talk to the providers at all. So by default, rural patients could say, you mean if I just drive down the road to my urban center, that I might not have to pay as high a quality, they literally changed the plan design based on this network that wasn't even negotiated with providers, based on publicly available data. So they're moving people to see where they can measure, and they're going to just decline you if you're not in there. So in short, thinking like a payer, managing the medical budget involves risk and analysis, which requires statistics. And in these statistics are outliers. And because of the tyranny of small numbers, rurals are outliers. And we can be unimportant, or we can decide to be very important. And I think that working collectively to represent 60 million people, or 20% of the population of the country, is our opportunity. However, I think it's also very interesting that you in the Delta, as a collective, working under the project that you're doing now, could work towards the ability to have a single message of quality because of the way you're working collectively. So that's really one of the big opportunities. The end of the day of this section is that your data must reflect your story in order to demonstrate value. If you're not putting in your data, and that includes your claims, and the majority is in your claims, but if you're not putting the data, your story, then you are going to be bypassed. So how do you actually build a value story? And I think this is an encouraging part of it. The first is that the historical effect of the tyranny of small numbers is we are really good at changing on payment models and delivery models. We have a separate, long-standing, different payment model than everyone else, the all-inclusive rate. We also have designations like CAW and PPS. We have things like dish payments, though those are not as much around, but historically have been. And then, of course, just the designations of rural health clinics, and even the type of support through cost-based reimbursements. So this is not a new concept for rural providers. We just have to see it in that way. The other thing that I noticed and I would caution about is that, and actually when I did some research online about tyranny of small numbers, there actually is a tyranny of small decisions. And that is, if we deal with only the current, which sometimes seems to be the only way to do it with small numbers, we could have missed opportunities by not seeing the long-term trajectory. Those holding out to not participate in transformation could, in fact, miss the opportunities and suffer some unintended consequences. So that's just a cautionary note. The formula is our outcomes and our patient experience divided by our costs should equal value. And world and the commercial payers are following suit. The interesting thing to note is that this has been a study by the Healthcare Quality and Payment Reform. They identified 4 elements of any payment methodology. So this sort of really gives you the good instruction about where to focus on understanding any type of payment methodology. The first one is that the alternative payment model is offered in a way to reduce or eliminate barriers in the payment system. So an example of that is participating in an accountable care organization. It gives waivers of Stark and antitrust. The ability to collaborate based on cost and what other people are charging, that's been from a network perspective, a very difficult thing to overcome, that clinical integration piece. And the ACO is acknowledging that by you participating in an ACO gives you the acknowledgement that you are, quote unquote, clinically integrated, and therefore given the waiver of that type of legal concern. That's an opportunity. The other opportunity in an ACO is that Medicare gives you claims data, and it's data of competitors of everywhere that your patient goes. So they're informing you to be able to understand and see where your patient is and where they're going outside of your own billing, and have the ability to actually then manage that patient better. So that's an example of payment for services. Accountability for spending means again, in looking at the ACO side, and this can be translated in almost all the other payment methodologies, but for the most common would be the ACO, so I'm just sticking with that description. But for spending, what Medicare does is define a population and then look at what the total cost was for that population, not what they charged you or what you got paid for, but what did Medicare put out over the average of each one of those patients in a population that you were one of the providers. The average in the country is 7,000 to about 13,000, and ACOs are given a benchmark, which is what their pool of patients are and what the total spend is. If the spend, let's say, is 10,000 on their benchmark, and then they apply the things that ACOs say, prevention and wellness, reducing preventable admissions, those things are applied, and the total spend on average goes down $500 to $9,500. Medicare and shared savings will split that amount of savings with the providers in the pool. So, for instance, and that's $500 times 5,000 patients divided by the providers that were participating in that program. And creating an accountability of spending and rewarding someone for actually not having too much spending. The other is accountability for quality, and so a lot of times that's a measurement. Either it's a measurement that's reported, but it also may be observed. And then finally, patient eligibility, and this really is a function of defining the pool. So that's a requirement on the payer side, that they're not duplicating payments if that patient is going into a different program. So those four elements are in existence, and they do offer you great opportunities. This is another way to look at those types of four elements, and they called it originally the Triple AIM, which was better health, better care, and lower cost. Over time, it's been added the provider satisfaction piece, so we call it the Quadruple AIM. And what I tried to do in this slide was sort of define, based on payment or delivery form, what it looks like. And in delivery form for better care, that's really about not saying that you're giving bad care, but what they want is to see processes in place to manage this onslaught of the large amounts of populations with the chronically ill entering. So do you have processes in place? And do you have the ability to coordinate care for those patients, because they have complexities that need more than primary care? And lower cost really is about that total patient spend that I just told you about. And they are throwing money at it, saying that we'll pay you on a per member per month basis to do care coordination. So we'll spend, but we want the spend to have a result. And that's lowering the cost, the total spend, which means managing the chronically ill, keeping them out of situations that could have been prevented that are very high cost, like 3 weeks in the hospital. Then the better health is really measuring an outcome, and that's more of perhaps access to care. We are overburdened by patients on a daily basis, and the payment methodology has really pushed providers to be on a transactional reactive, that when someone is really ill, there's not urgent care, there's not real-time care, there's not access to care. Even, it's not just rural. I mean, if somebody gets diagnosed, it may be 3 weeks before they can get to a neurologist, and meanwhile, they're still sick, and it's still progressing. So the idea of having coordination plus a way in which you can change your practice so that there is access for that urgency, that really helps reduce the preventable admissions and duplication of efforts. And finally, this delivery reform on provider satisfaction is that, I don't think seeing 40 patients a day at 10 minutes a pop is really what physicians signed up to do. And I'm sure they don't think that. They've said as much to me. And so having the ability to somehow, in comfort of the physician being in charge, being able to, of their patient, which they are not work 40 patients a day at 10 minutes. And that is really operating at the top of their license, giving the ability to have nurses that can support that care plan that's built for the sick of the sickest, and being able to have time for patients that they might spend more time with in the mornings or whatever time of day it's fixed, so that they have the ability to do that. Those things are what would create provider satisfaction and help us specifically in the rural markets where it's really difficult to recruit physicians. So I'm going to break these aims down just a little bit, and the lower cost is to reduce total patient spend. So having processes that would reduce preventable admissions, reduce duplication of services, and reduce preventable ER visits. It doesn't mean that you shouldn't have people in the hospital. It doesn't mean that they want to pay less when they are in the hospital. But if there's a way that they can pay you, a third less of caring for that patient without them being in the hospital, being so sick that they can't really recover. So that's one step. The second is provide better care, and that really translates to efficient care delivery. So in the field, what we see is that means provide prevention and wellness services, and that means an assessment of the patient, generally done by a nurse, and I'll speak to that in just a second. It also means utilizing new codes and services for care management, so that speaks specifically to the chronic care management CPT code and the new telehealth code. Also, you need to have a way in which you can identify patients that have these disease states and then get them into the processes that you have. This actually helps improve the workflow, but doing that initially is cumbersome, to say the very least. Documentation thoroughly, that speaks to hierarchical condition category codes, and I'll speak to that in just a second. But having documentation of the patient's disease state is imperative. And then finally, being able to figure out how to manage the chronically ill. That sort of goes back to that 20/80 rule in business. You need to be able to manage 20% of your time exclusive to a smaller population in order to be able to cover it so that you can have care delivery for everyone. Then finally, of the Triple AIM, better health, that really talks about better health outcomes, which means fill the care gaps, create more access to the chronically ill, manage the patient and disease through consistent evidence-based processes, and then encourage patients to participate in prevention and wellness. This really gives the opportunity to do outreach, and that's another thing that really changed in Medicare's perspective, is the opportunity to actually recruit patients. So just a few last slides on population health strategies, and they're focused on workflow and process, prevention and wellness, and coding and documentation. These ideas come from the Practice Transformation Program that was across 4 years of Medicare, really trying to aid folks in helping to transform practices to be ready for this population and value-based payment world. So modifying workflows to address care gaps. The study in the ACO company that I worked with, Caravan, it was a projection that every patient would need to have a visit in the clinic for an hour, every patient, an additional hour than what they're doing right now. And probably if there's any practice managers in the line, they might not like to hear that if they have 3,000 patients, they need 3,000 more hours in a year. That's hard to do. If you're able to actually include a nurse-led annual wellness visit program, it gives the opportunity, number one, for a new visit. Number two, it actually gives the nurse to spend 45 minutes and do a full intake and an assessment, and then be able to then hand that off to a physician that has been overseeing the program. So that creates new revenue, and that also creates a way in which that you can then have a better idea of the data set to show what the population that you're serving really is. You probably know it already, but where's the proof? Who are the diabetics with the A1Cs out of control systematically? So having a nurse-led care coordination and annual wellness visit program gives you that opportunity to change the workflow and address care gaps, and also to use data to inform the process. The other is that you really need to have some type of IT infrastructure. We all certainly try to invest in that when meaningful use came out, however many years ago that was. But perhaps those IT infrastructures aren't necessarily serving you to the degree that they could. So necessary infrastructure really refers to the ability to do annual wellness visits that have documentation that push out the quality codes. You want to be able to identify those patients who are at risk and then also do pre-visit planning. So you have the opportunity to do some documentation as well as address the patient's needs in advance, to prepare in advance. And then in the value-based care world, you really want to be able to build primary care relationships. This helps pull your patients closer to you. If you're the one doing the primary care, then you have the ability to have those attributed to you in those measurements of patient eligibility. In prevention and wellness, I spoke about the annual wellness visits, and that's really an interesting single event that in the world there's about 30 measures that you're reporting on, quality measures. 11 of them come from an annual wellness visit. 17 come from data. So the majority of work is whether you're documenting your claims or you're documenting in a really robust annual wellness visit. So those two are really big wins, big fast wins to do proper documentation and to do annual wellness visits. The other on prevention and wellness is this care coordination does a lot of things that I've spoke out about already, which is patient satisfaction, provider satisfaction, having the ability to have a care plan, have the nurses extend the care beyond what happens in the practice. And then finally, I would say deploy secondary prevention. There's actually prevention that is in early diagnosis and treatment that prevents the progression of the disease state. Finally, coding and documentation. This was a real interesting sentinel event in the practice transformation world, in that when you're paid on an encounter reimbursement, you're really paid on one diagnosis and treatment, or let me say on the encounter based on the severity. And you only had to put down 4 types of codes perhaps, or maybe the EMR only allowed those 4 types. But normally, if a patient has two comorbidities, they probably have 5 disease states. And in those disease states, that could equate to 11 or 12 or 15 different types of things that need to be noted that are being managed. And we met a lot of resistance in the EMR world about documenting that way. The other thing that was interesting about that documentation is that a payer, particularly Medicare, but other payers, do not have business intelligence moving forward, corporate knowledge moving forward. In other words, the condition, any condition is not carried forward. It's started over each year annually. So, for instance, if you're seeing a patient that's an amputee, and really that's not the prominent thing that you're seeing that patient for, if it hasn't been documented in a year, the government doesn't see that person as an amputee. And so that severity of that person, when you're being measured, is not represented in the data. So the hierarchical condition category codes actually allow for that. Another example is actually just putting down diabetes versus diabetes with retinopathy or neuropathy. The weight of the value, actually it's about treatment. So the measurement is how much time does it treat someone who is very sick or not sick? What allocation are we willing to pay in time for that patient to be treated? And so having the ability to huge difference in value-based payment world. The other thing is document in the right place. And I will say that what happens when you purchase an EMR, just like with a phone, you have to customize it. And when you start customizing, it's a one-off in the backside of the data sets. And if you're not careful, if you're creating some templates that are not connected in the proper way, when you run reports, all of those documentations might not carry forward. So it's critically important that when you're beginning your documentation and looking at your reporting, that you check that and make sure that your IT folks are able to tie whatever your templates are back into the place that it will be in the EMR, so it'll show up in a report. And you also can also be prepared to report manually, but if you report manually, most likely it's a small subset, but you need to know where that documentation is. So, you know, the idea of documentation, coding, and reporting is that you're going to know what you're reporting on when you're building your reports and building your templates. So, getting close to conclusion here, what is the rural value story? I say the rural value story is that we carry a lot of weight, and it's important, and it's beyond more than the normal. We carry that weight of 60 million people, 20% of the population that are considered in the outlier pool. And so I think by documentation, putting a truth out there, having the ability to negotiate based on that value story gives us the ability to become high quality and most coveted providers for rural patients. It's going to come from documentation. So a quick little formula to leave you with, and that sustainability of rural health is dependent on fair and equitable payments, and the payments are dependent on documented results. So the formula for results is measurable positive changes in available data. Available data means claims and some reports. And then finally, providers are measured on the results of those claims and other data, and your revenue ultimately is impacted by this data. So that gets you in the circle of sustainability. Finally, my favorite slide, data must reflect your story in order to demonstrate value. With that, I'll pass it back to you, Kate, to see if there's any questions.
Thank you so much, Shannon. That was great and wonderful, lots of information on there. So as a reminder, you can press *2 to unmute your line and ask a question to Shannon, or you can use that chat box and type a question in to the chat box as well. So we do have a question from Brian. You mentioned hierarchical condition codes. Are critical access hospitals going to be required to use the hierarchical condition codes, and if so, when? Are they tied to reimbursement?
Yeah, so the hierarchical condition category coding is a method used by Medicare Advantage plans. It's not a requirement, but it's how they measure. So it's an opportunity, not a requirement. Hopefully that answers your question.
Thank you. And it looks like Tori is typing, so we'll see if a question's coming in from her. Just a reminder, you can press *2 to unmute and ask a question, or again, use that chat box.
So while Tori is typing, I will say there is a method about how HCCs work, but it's really about weight against the payment based on the severity of the disease state. So it would come in the lump sum for negotiation. Will payers begin to look at all data so that every case is reviewed and looked at for value? I think payers are looking at I'm not sure, are you asking all payers look at all data as in each other's data? And if that's the question, then I would say no. They're going to look at, like Medicare will look at all Medicare data. And then in payment methodologies that look at patient eligibility, they'll narrow that down to that patient pool. And in that case, they will look at all data, not just the data that you produce, but the data of every single place that that patient has been. So they're looking at, let's say a patient comes to you, has a primary care doctor, maybe has some visit to the hospital, then gets referred to an urban center, then gets referred to 2 or 3 specialists. When you're in the ACO, you actually have the data of every single patient, every single provider that they've been to, and you can actually see where the patients are going and what the cost was for that patient to go there. I hope that answers your question.
This is Lisa Castile. Am I unmuted for you to hear me?
Yes, I can hear you.
Yeah, go ahead, Lisa.
And just to add to that question, oftentimes in some of the surveys like Leapfrog or some of the Blue Cross Blue Shield, and maybe even some of Medicare, when we're looking at different service lines and programs, they will not use our data because it's not enough cases. So at some point, will they use every case, like in the certification of quality programs and things of that nature?
Right now, I don't see that, and I think that it's not to say that they won't, but they're putting us in the entire pool of all providers and doing their own analysis, their own statistical analysis, and so.
So you do see where that is an issue for us. You know, I may have 150 cases, but they want 200 cases. But my 150 cases may be of great value because it costs less and my quality is phenomenal, but I don't get a representation because it's less than 200 cases.
Right, absolutely. I mean, I think that's what the problem is, and I think that that is something that needs to be addressed as a collective group. I mean, the example I use is I had a small rural hospital that, was asked to report of the number of people that admitted into the ER with a myocardial infarction, how many of them got aspirin within 15 minutes. They only had 3, and every one of them was a unique situation. So the answer was none. And I mean, that's that question and that weight and that methodology is not applicable in some ways. So I think what has to happen over time is that we have to argue the point collectively that low volume sets make us an outlier, so address us as an included important outlier.
And then a second point that I think happens with CMS when they compare costs collectively across the entire United States, they move everybody to a wage index of 1 and artificially inflate our costs. They don't represent real payments to people. So what they show for California is a lesser cost, and what they're showing for Tennessee is a higher cost because they adjust those information. They ingest that information.
Right. And so I think that one of the things that we saw happen in about year 4 of ACOs in general was that they were starting to regionalize the measurements and recognize that cultural difference. They also then did that adjustment on the wage index costs for rural providers.
I think we're going to need some assistance in the political arena in helping them to understand that, because those are very complex calculations that just really don't happen in any other industry, and it happens in healthcare. And so when you say I pay $1 for this service in California, but I also pay $1 for it in Tennessee,